Introduce you. Melissa is our oncology physician assistant at Lurie Cancer Center. She started her career in oncology at the University of Chicago Medicine in 2011, and she joined us at Lurie Cancer Center in 2014. And Melissa has both inpatient and outpatient stem cell transplant experience and developed our Northwestern Medicine Stem Cell Transplant Survivorship Clinic in 2021. She's going to speak to us today about the elements of a patient's personal survivorship care plan, which I think, Melissa, we might have some questions already waiting for you in the Q&A, but we'll let you go through your presentation and we'll see what is left to be answered at the end. So welcome, Melissa. Thank you for joining us.
Perfect. Thanks so much, Diane, and thanks everyone for being here. I know everyone has pretty diverse backgrounds in terms of what cancer perhaps they were diagnosed and treated for, so I tried to make this a pretty basic and well-rounded presentation so that it applied to as many of you as possible, as opposed to really like honing in on one specific type of cancer or cancer treatment. So with that, we'll go ahead and get started. And today I'm going to be talking about the elements of your personalized survivorship care plan. And before I begin, I always like to stress to my patients when I see them that this is not meant to increase anxiety or increase worry. I really want to make you feel empowered to participate in your healthcare and to make an impact on your future health, because as a lot of you know, throughout cancer diagnosis and treatment, you're not given a lot of choices, and oftentimes you're sort of just told what to do. But going forward, you do have the opportunity to help sort of take charge of your health and help to improve your outcomes in the long term. So with that being said, our objectives today are to explain the importance of cancer survivorship. We'll talk about the mission of our Northwestern Survivorship Program, outline the development of a personalized survivorship care plan, and discuss the potential long-term and late effects of treatment. And again, just because these things can potentially happen does not mean they're going to, but we found that the outcomes are better when people know what to look for and when we're screening people appropriately. In talking about cancer survivorship, we have to ask ourselves, why is survivorship important? And excitingly, the number of cancer survivors is increasing, and that's due to several different factors. We have more treatment options than we've ever had before. Our outcomes are improving. There's more indications for treatment, and we're able to treat older adult patients with reduced intensity therapies. The goals of cancer treatment are truly not only to cure the underlying disease, but also return survivors to an optimal state of health and well-being. So I always tell people, if I cure someone's disease, but they have not any quality of life afterwards, I really don't feel like I'm doing my job. My job is to not only make sure the disease is cured, but also to make sure that they're able to enjoy their life and participate in their life in the years to come. And in order to meet these goals, we as healthcare providers must address the issues that our survivors face. When we talk about the purpose of our survivorship program here at Northwestern, it's to ensure that our patients are evaluated for long-term and late effects after their treatment. Some of these things could include organ system function, bone health, secondary malignancies, growth and development of our pediatric survivors, reproductive health and fertility, and sexual health. Our survivorship clinic visits allow adequate time to address the issues survivors face. And I really like to highlight that we spend a lot of time creating our survivorship care plans, and we have a lot of time to spend with our patients. So most of our new patient visits are usually about an hour long, and that tends to give us enough time to really go through, explain the survivorship care plan, and also talk about sort of our action items going forward with ways that we can help you and different ways we can promote your health going forward. So in meeting these goals, we have to address the physical and functional impairments that our survivors face. So things like talking about musculoskeletal pain and stiffness, fatigue, altered sexual health, chronic graft versus host disease for our stem cell transplant patients, and the many neurocognitive changes that can come with receiving certain treatments such as chemotherapy and radiation. In addition, we also have to address the psychological impairments. So it's normal when you don't feel physically well that your mood is also affected. So oftentimes this ongoing physical distress can exert a negative effect on our emotional well-being. Sometimes people might have depression or anxiety or poor self-image, poor self-esteem or body image changes. This is especially common after treatment that involves surgery that might change the way you look or leaves you with scars which act as reminders of what you've been through. Treatment may also even cause you to gain or lose weight, which may make you feel uncomfortable in the way that you look. Understandably, a lot of people have this fear of recurrence where they have symptoms that come up that understandably create a sense of anxiety about what's causing the symptom, or is this a sign of an underlying disease or pathology? Oftentimes people are worried about their family or the future, and they may experience survivor guilt or even post-traumatic stress disorder from their treatment and diagnosis going forward. Besides our physical and psychological impairments, there are also some social and spiritual impairments that we have to address. Things like altered sexual health, reduced or limited social interactions and activity. And that can be, due to recovery. So, recovering from a surgery, you may not be able to do as many things as you used to do. You may be at high risk of infection. So you may not be able to go out in public like you were before. Or it could even be self-imposed where, maybe you're just not feeling up to it. You're tired. You don't really want to talk to a lot of people. Other social and spiritual impairments can include the ability to work, strained personal relationships, concerns about finances and insurance, loss of hope at times, or even a spiritual crisis with a loss of faith or loss of life purpose or meaning. One of our biggest goals that we try and do within our clinic is to provide health maintenance and counseling. And what I tell patients is that understandably throughout diagnosis and treatment, most people lose track of their primary care physicians. They're focused on seeing their treatment team, getting their treatment, and getting to the survivorship phase of care. Survivorship really provides a chance for us to reestablish care with the primary care, as well as to catch up on our routine health screening. So a big part of our visit is focused on health maintenance and counseling moving forward. So one of the things that we'll do, and I'll get into more details about this as we move forward, but we talk about the risk of secondary malignancies, which are actually cancers that can be caused from the treatment. We discuss the importance of self-examination. So things like skin exams, self-breast exams, self-testicular exams, or even examining within the oral cavity. We really encourage all of our survivors to practice meticulous oral hygiene. It's very common after receiving treatments such as chemotherapy and radiation that people may have changes within the mouth and oral mucosa that can lead to more cavities. So things like routine dental care become really important once you're cleared by your oncologist to go back to the dentist for a routine cleaning. Of course, we always recommend avoiding use of tobacco products, practicing modest alcohol intake and avoiding illicit drug use, and then getting into new habits of restful and adequate sleep, which can be understandably difficult after treatment. A lot of medications, things like steroids, can interrupt sleep, or if you've been hospitalized for a period of time, your sleep cycles may be off as you've been getting woken up throughout the night for vital signs and medications. We talk a lot about sunscreen, protective clothing, how to prevent secondary skin cancers, maintaining a healthy weight through diet and exercise, and regular exercise. So our goal here is usually about 150 minutes a week, which sounds like a lot, but it's really about 30 minutes, 5 days a week. And I always tell patients, this is our goal. I don't expect anyone to be doing this immediately after treatment. I recommend starting slow, maybe 5-10 minutes every other day, and then gradually building up. Reducing stress, which is often more easily said than done. Eating a nutritious diet, so focusing on things like fruits and vegetables, or even meeting with a dietitian to talk about different dietary changes that could be helpful moving forward. And then seeking out counseling and therapy to improve our mental health going forward. In talking about how our survivorship program meets these goals, we provide what's called a survivorship care plan for our patients and share it with the primary care physician as well as the oncology team. This helps to increase our survivors' understanding as well as outlines the follow-up. So people are more likely to be compliant with our recommendations if they understand A, why are we recommending this? What is this based on? And B, if they have it written down and know what to expect moving forward. Our goal is to improve the quality of life and patient self-efficacy, provide guidance for healthy behaviors, establish survivorship as a distinct phase of your care, and also offer our expertise, guidance, and support to you as well as your support system from diagnosis throughout the path of wellness. When we talk about the survivorship care plan itself, there are several different things that our survivorship care plans do. So it's really going to outline the diagnosis and treatment history in a concise format. So this is not going to include every little detail, but rather it'll include the diagnosis, the timeline of treatment, the names of the medications you received, perhaps the dose if our recommendations are dose dependent. And this is especially important as you're seeing a primary care doctor, if you travel, if you go see another physician outside of Northwestern, it gives them a nice, concise summary to work from. So that way they're not trying to go through thousands of pages of records and you're not responsible for trying to regurgitate every piece of your treatment history as part of your visit, because essentially we want your visit with another doctor to be talking about why you're there and not, just going through everything you've been through up until that point. It also will include individualized follow-up recommendations based on your prior treatment history. It'll talk about the recommended routine health maintenance based on current guidelines. We also include it in our medical record here at Northwestern, so any of our Northwestern physicians have access to this. And I will say, especially recently, a lot of our primary care doctors have been looking at these, have been reaching out to Karen and I to make sure that they're, following along and doing, sort of the recommended guidance or asking questions, which I think is a huge improvement from how things have been in the past. What does the care plan include? So at minimum, it includes the diagnosis, the treatment provided, different supportive resources, psychosocial resources, nutritional resources, not only here at Northwestern, but also in our community. It lists out the contact information for the personnel involved in your treatment. So not only for yourself, but again, if you see another doctor and that doctor has a question, they're able to easily figure out who to reach out to and how to contact them. It talks about potential future symptoms or toxicities, our recommendations for wellness and prevention. Genetic counseling and testing information is on there if it's applicable to you. And then also referral contact information for specific follow-up care that we might recommend. As we get into potential long-term and late effects of treatment, again, I just want to remind all of you that these things can potentially happen, but it does not mean they will happen. Our goal is vigilant surveillance and preventative care. So a lot of what I'm talking about today is just to give a background of why we're recommending some of the tests we're recommending and how we can promote your health going forward. So as you can see here, cancer can affect a number of different areas within the body. It all depends on the type of treatment you receive, the age at which you receive the treatment. And I'll use the next few slides to really provide more details on specific long-term and late effects. But please note each survivor needs an individual care plan as their risk is truly individualized based on their prior treatment history. And some of these things may not pertain to you. So when we talk about our cardiac effects, this is referring to the heart. And common treatments that can affect the heart are anthracycline chemotherapy agents, high-dose cyclophosphamide, or radiation to the chest wall. The effects on the heart can sometimes be a weakening of the heart muscle called cardiomyopathy, valve issues, heart disease, or an inflammation of the sac around the heart called pericarditis. There are certain comorbidities like high blood pressure, high cholesterol, diabetes, or obesity that can also affect the heart. And that's why a lot of our visit is spent talking about managing cholesterol, managing blood sugar, diet, and exercise to help prevent these comorbidities from compounding your risk. The treatments specifically associated with cardiac effects, anthracyclines are the big one that we talk about. So this is a class of medications that can affect the pumping mechanism of the heart, compromising heart muscle function, as well as the heart rhythm. So the electrical pathways of the heart may be damaged. It can cause high heart rates, slow heart rates, irregular heartbeats called arrhythmias. So a lot of what Karen and I do are looking back at the chemotherapy you received, and if you had an anthracycline, calculating what the lifetime dose you received was, and then according to guidelines, deciding what the screening should be. Chest radiation can also result in valve issues, heart disease, or this inflammation of the heart. And again, aging and other comorbidities can affect your cardiac outcomes. So what do we do to screen for cardiac effects? Oftentimes we're doing what's called an echocardiogram. Many of you may have had this. It's an ultrasound of the heart. They put the cold jelly on your chest. They look at the chambers of the heart. They measure how well it's pumping. Other times we get a test called an EKG that specifically looks at the heart rhythms. And the exact timing and frequency of these screenings are based on guidelines. So it's not just, making something up like, oh, this person needs this screening this often or this screening this often. It's all laid out for us by specific guidelines from the NCCN and the Children's Oncology Group. And again, we use these cumulative doses of chemotherapy agents and radiation to help us determine what the screening is. And then we also ask a lot of questions at these visits. So I have a lot of patients who get frustrated with me because I'm delving into their family history and their personal risk factors. And, they're like, oh, it's in the chart. It should already be in there. It should already be in there. I'm like, I know, but this is actually really helpful for me to just individualize, based on your personal history. Maybe we need to do something more or less frequently. Let's say if you have a strong family history of cardiac issues, or if you've never had any family history of cardiac issues, that may also impact some of my decision making. I'll also say some of these tests aren't well defined in the adult population, and a lot of primary care doctors are not aware of the cardiac risks of these treatments. So sometimes we even have to rely on patients to sort of teach their primary care doctors, like, hey, I had chest radiation. I need to be taken seriously, especially with young patients who get chest radiation. The last thing I want is them to show up with a cardiac symptom and someone to pass them off and say, oh, you're young, you're healthy. That patient will then really have to advocate for themselves and say, you know what, I had radiation in my chest. My survivorship PA or nurse practitioner told me I need a cardiac workup, like take me seriously. So again, a lot of this is about advocacy as well. When we talk about pulmonary effects, this is referring to the lungs. And again, there's a number of different chemotherapies that can sometimes affect the lungs, as well as chest or total body radiation or chronic graft versus host disease in our transplant patients. And the main effects we see on the lungs are inflammation of the lungs, or potentially even scarring of the lungs, which makes it more difficult for the lungs to exchange oxygen and carbon dioxide. Our tests that we would do to screen for pulmonary deficits are things like pulmonary function tests. We always recommend, stopping smoking, avoiding smoking. And then after certain types of treatment, we even recommend patients have specific precautions related to scuba diving or anesthesia. Again, we would go through this with you in clinic and let you know if this pertained to you. It's also really important to receive some of our routine vaccines. So things like the flu vaccine, the pneumococcal vaccine, the COVID vaccine, because we want to reduce any risk of injury to the lungs. So if we can prevent you getting the flu, essentially we're helping to prevent more damage to the lungs. We can also use medications like bronchodilators that help relax the muscles surrounding the airways to help make the airflow easier. In talking about ocular effects, so this is in regard to your eyes. Oftentimes, certain forms of radiation, steroids, chemotherapy called busulfan, and again, chronic graft versus host disease can affect the eyes. And the main effects we would see are things like cataracts, glaucoma, or lacrimal duct scarring. Our primary intervention and screening for ocular effects is going to be your annual eye exam. We do typically recommend this is with an ophthalmologist, and we would recommend it's a full comprehensive eye exam, including the dilation of the eyes. Cataract surgery can be done if needed. And some people need what's called lacrimal duct stents. That's essentially a little stent that's put into the tear duct to help open it up to allow the eye to be lubricated again. And now I'm going to get into secondary malignancies. And I will say, as a healthcare provider, this is always a real challenge for me to talk to patients about. One, because you've already been through so much, and two, because the word cancer and malignancy is such a buzzword and such a trigger word. So I do want you to be aware of these risks. But again, it's going to all depend on your past treatment history. Overall, secondary malignancies, are relatively rare, and typically we can try and screen and prevent them. It's just another point where I'm saying, we can do preventative medicine here. So this is why we're recommending things like your routine mammograms and colonoscopies. It's not because we want one more test or appointment for you. It's because at times there are cancers that can be caused by the treatment you received. So there are several different types of secondary malignancies. I'll go through each one. Starting out, we'll start with blood cancers. So the therapy-related blood cancers that we see are typically myelodysplastic syndrome and acute myeloid leukemia. And again, this is very rare to develop it, but certain types of chemotherapy can contribute to developing therapy-related blood cancers. Our main screening for blood cancers are those CBC blood tests. So a lot of patients will say, I'm not sure why my oncologist wants me to keep getting blood work. I'm done with chemotherapy. And the reason why is because we're monitoring your blood counts from here on out. It's also really important for patients to be aware of worsening fatigue, pallor, pale skin, or if they start to notice really easy bleeding or bruising, I'd want them to contact their oncologist to get a complete blood count to make sure their labs look good. Another secondary malignancy that we focus on is skin cancer. And skin cancer can be caused by radiation, being on immunosuppression, or chronic graft versus host disease, which can cause squamous cell carcinoma of the skin and head and neck. And our main screening for this is our annual dermatology total body skin exam. So this is seeing a board certified dermatologist. They look at you with what's called a dermatoscope from head to toe. If you've had any radiation, they'll do some special focus on irradiated skin fields. And it's important to know that skin cancers don't always occur like right after treatment. Sometimes, and most often, we see these things 10, even 20 years after therapy. So just because the treatment's ended, it doesn't mean your risk has gone away. And so that's why we always encourage you every year to have your skin exam, wear your sunscreen, avoid the most intense periods of sunlight during the day, not to go to tanning beds. Check your skin on your own. If you have a new mole, contact us. We want to be helpful to you, and you're not bothering us. So if something new comes up, please let us, your oncology provider, know so that we can help you manage it. Another secondary malignancy that we can see is breast cancer. And typically this is caused by radiation involving the chest wall. So, at times people who have had, say, Hodgkin lymphoma might get chest radiation, and they tend to be at higher risk of breast cancer. Our screening for this is our annual clinical breast exams. That's with a physician doing a breast exam in clinic, as well as an annual mammogram. So the age and frequency of screening mammograms can depend on your treatment history, your risk factors, your family history. The general population usually has screening mammograms starting at age 40 and repeats it once a year. There are people who will start them younger or even have added screenings such as breast MRIs based on their breast density or based on their treatment history. And that's something, again, that your survivorship care plan would go through and tell you. Another secondary malignancy that we can sometimes see is thyroid cancer, typically with radiation that involves the neck. The main screening is a history and a physical exam. It includes a thyroid blood test here at risk, if you're at risk. That doesn't typically detect thyroid cancer. It mainly detects abnormalities within the thyroid that can happen after radiation or certain types of treatment. Immunotherapy, stem cell transplant can cause some, hypo or hyperthyroidism that we screen for. But again, the best thing is truly the physical exam where they're feeling the thyroid, and is most commonly done at your annual primary care visit. The other secondary malignancy we talk a lot about is GI cancer. So things like colon cancer that can evolve from radiation to the abdomen, spine, pelvis, or total body. And our screening here is colonoscopy, which no one really likes to get, though some people have told me it's the best sleep they'll ever have once they finally get through the prep. The age and frequency, again, depend on your treatment history, your risk factors, your family history. The general population, they have lowered the age. It used to be age 50, and now it's been lowered to age 45 for everyone. And we repeat it at least every 10 years or more frequently based on the findings or based on your history again. And then bone health is something that I do talk a lot about. This photo depicts elderly adults in this picture, but after cancer treatment, bone health can be impacted even in young patients, and it can cause quite an impact on their quality of life. So certain medications like methotrexate or steroids, aromatase inhibitors, things like letrozole or anastrozole, or even stem cell transplant can impact the bone health. And the two main effects that we see are reduced bone density, things like osteopenia or osteoporosis. And then steroids can cause what's called avascular necrosis, which is a decreased blood supply to the bone that can cause pretty extensive pain and discomfort. Our screening for bone health is a bone density evaluation to look at the bone density. And then if we were worried about the avascular necrosis, typically we would have you get imaging studies and see an orthopedic surgeon for further management. Our interventions are going to be age-appropriate calcium intake through your diet, so through the food you're taking in, as well as supplements if you're not able to get enough from your diet, adequate vitamin D intake, weight-bearing exercise. Sometimes people need pharmacologic interventions. So these are actually medications that are used to help preserve bone health and strengthen the bones. And we may refer you to an endocrinologist or a bone health specialist or an orthopedist for further management. And I always tell patients, especially my younger patients, so it may not seem like a big deal, but bone health can result in major quality of life issues, fractures that require surgery or hospitalizations. So it may seem, silly to get a simple bone density, but honestly, this can really affect your quality of life. And it's a pretty easy test. I always tell my patients, it's for the blood cancer patients, it's not a bone marrow biopsy, it's a bone density. It's an x-ray typically of the spine and the hips, again, to assess and make sure that your bones are healthy and strong after getting your treatment. In regards to reproductive health and fertility, certain cancer treatments can impair our reproductive health and fertility. The most common causes are the alkylating agents and platinum agents of chemotherapy, radiation to the reproductive organs, as well as to the head and to the total body. And then certain types of surgery, like pelvic surgeries, can affect your reproductive health and fertility. Our goal with fertility preservation is to discuss this before treatment starts. So oftentimes people will have the time or the availability to actually preserve their fertility. So for males, it's obviously a little bit easier than females with a simple, sperm banking collection. Females often require being at a certain time in their cycle to collect eggs. But again, knowing about the risks ahead of time, I think is really important. And we do have a whole oncofertility system and an oncofertility navigator, Kristen Smith, who's a nurse who's amazing to work with. And because of the research done here at Northwestern back in 2017 or 2018, actually, Governor Bruce Rauner at the time signed a bill that would help to promote oncofertility insurance coverage here in Illinois. So if people who are undergoing cancer treatment have an impact on their fertility, there are some insurance coverage benefits at this point in time. The Oncofertility Consortium is a reliable resource for patients. And if you need any more information, honestly, you can just Google Oncofertility Consortium and it will pull up a plethora of information on that website. When we talk about sexual health and sexual functioning, so I always tell people, do not be afraid to bring this up with your oncology team. It can certainly be uncomfortable, but it is a normal part of life, and it can also, really impact quality of life. Sexuality also tends to be dynamic, so sexual health may change throughout your diagnosis and treatment. It may not be something that's super important in the beginning, but as you finish your therapy and you're feeling better and move on, it may become more important to your life. There are certain chemotherapies, medications, radiations, and surgeries that can impair sexual health and sexual functioning. As we discussed, this is dynamic throughout the course of treatment. And we have many specialists available to help with concerns such as urologists. We have a sexual medicine and menopause clinic for females, pelvic floor physical therapy, and even psychologists with training in sexual health. As you can see from this slide, there are a number of psychological effects of cancer diagnosis and treatment. Oftentimes, I tell people that survivorship can be sort of the start of the psychological effects. Throughout treatment, we say jump, you say how high. But after patients have completed their therapy, they have time to process sort of what just happened to them or what could have happened. Their safety net's been removed, appointments are spaced out. They may develop this fear of recurrence. Triggers may evolve, such as anniversaries, and the return to normal life may be challenging for some people. Everyone deals with cancer diagnosis and treatment in a different way, and there's no right or wrong way to deal with your diagnosis or treatment. I just strongly encourage you to accept help, to consider counseling if you need it. And if you feel like you're doing really well from a psychosocial standpoint, I also encourage you to get involved because you can be a really helpful advocate, especially to other people who are going through something similar. When we talk about our resources to promote our psychosocial health, we have a strong supportive oncology team here at Northwestern. It includes social workers, psychologists, dietitians, fertility navigators, young adult navigators. We have a tobacco cessation program as well as nurse navigators. We have our financial counselors, there are support groups within the Cancer Center, and even basic things such as applications like Calm, Pause, and Breathing Zone can help with sleep and mindfulness. I like to remind people not to wait until they're at a breaking point to ask for help. We're in the midst of a major mental health crisis, a lot of which has been induced due to the pandemic, and it may take several weeks to get in with a mental health professional. So it's always better, in my opinion, to have an established relationship with someone before you get to a breaking point. And your symptoms may not always be the typical depression or anxiety. It could be things like you're just not feeling that motivated or can't concentrate. Even something as basic as decreased libido or apathy can sometimes be a sign that it might be helpful to talk to someone to get through this. In regard to our local programming, so these are some of the local programs that we have available to us. I would also say, one of the silver linings of the pandemic is that a lot of these resources are now virtual. Our supportive oncology team is now doing a lot of virtual visits. So if, you're far from Northwestern, like due to distance, proximity, or if you're just busy, you work, you have kids, or just can't make it down here, I do think that that's made these resources more accessible to our patients and increased access to them. So sort of in summary, our job as survivorship providers is to know the history, and then based on history, all else follows. So again, Karen and I spend a pretty significant amount of time creating these care plans based on the history, and then meeting with you, learning about your history, learning about yourself, your family, your support system, and then seeing how we can help moving forward. And with that, I will take questions, and I'm happy if you want me, Diane, I can talk about the myeloma question if you want.
Sure. Actually, Melissa, if you don't mind, there are several questions in the Q&A about
Sure.
specific diagnoses
Mhm.
that might not have been on the list of people that you see in clinic. So there
Sure.
was a question about Brain Tumor Institute. There was a question about, again, gynecological cancers and endometrial. Could you just kind of maybe give your advice on what people should do to pursue survivorship in their own disease space?
Sure. Yeah. So I think one thing is to ask your treating physician. Like some of these programs do have a nurse or a nurse practitioner, a PA who can put together a survivorship care plan and go through it. So I think asking the specific program that you're in, the physician that you're seeing, if they have a survivorship program or if it's possible, that a nurse or an advanced practice provider could put this together for them. The other thing, which this is going to sound very silly, but I know even myself being a patient here, that we all get those annoying surveys at the end of our visit. Like as we're walking out the door, it's already emailed to me, let me know about your visit. And Northwestern does take patient input very seriously. And I think if this is something that you want and that you're interested in, even a simple note in that comment to say, I would really like to see a brain tumor survivorship clinic. I would really like to see a dedicated gyne-onc survivorship clinic. I think those things are taken seriously. And I think that eventually our goal is to have funding for all of these different programs because they're all incredibly important. But truly right now, it's just like a bandwidth issue as well as, what and what you're comfortable with. So for instance, my background is in blood cancers and transplant and now breast cancer. But I do think there's room and space to develop all these programs. And I do think every cancer should have a dedicated survivorship program. So please, I mean, it seems silly, but take 3 minutes to write that in your comments and ask your providers, because the more that you ask for it and request it, I think that they'll start to develop these programs.
So there's a question about if you were to develop a symptom, when do you go back to what's the timeline of when go back to your oncologist and that team versus you just call your primary care doctor? So, if you're in surveillance or it's been a while since you've been connected to your team, how do you decide who to call if you find something based on some of those self-care things that you went over in your slides?
Sure. And that's a good question. And it's different, obviously, based on everyone's, specific history. I don't think it hurts to message the oncologist. My thing is we're here to help. The oncologists are here to help. We want to help. So if there's a symptom that's new and persistent and you're worried about, I think it's very reasonable to, if it's not something super acute, to send a MyChart message and await a response from the oncologist, knowing that their response may be, thank you for letting me know, please contact your primary care doctor. That at least lets them sort of triage it and sort of say, I don't think this is related, and the primary care can manage it. Certainly if it's something acute, like I've come in on a Monday morning after being off on Saturday, Sunday to like a MyChart message about shortness of breath or chest pains, like those are things you're going to an emergency room for. Or if it's something, even like a fever, something more acute, I would say don't MyChart, because MyChart messages, I think it's like 48 to 72 business hours. Because remember, your doctors are in clinic seeing patients all day, so they're not always just on the computer reading the messages.
So I guess kind of to wrap this up, because that was the bulk of the questions, and there are asking about specific services for certain cancers and how they would get plugged into there. And then also this question about, who primary doctor versus oncologist. But I guess to wrap it up, I would encourage anybody that's after Melissa's presentation, if they don't see that survivorship opportunity being offered, to approach their own oncologist and explain to them that you are informed about this, you think it would play an important role in your ongoing health care, and to ask questions about where you can get the resources if they're not available through our own survivorship clinic because of the diagnosis. There are resources out there in the community, but I know that our specialty clinics are very plugged into support services and also to aftercare. I mean, all of these interventions that Melissa's talked about and that Karen brought up earlier are related to guidelines that are spelled out by disease. So anything else to add, Melissa, kind of as a wrap up?
No, the myeloma question again is a similar response to the other diseases, though I will say if someone's had an allogeneic transplant for my multiple myeloma, I will see them in my clinic. Multiple myeloma is one of my favorite things to talk about, only because there's lots of great new treatments and hoping to find a cure for multiple myeloma. So I think the evolution of survivorship is going to be, a lot of these cancers are going to be treated like, maybe chronic diseases going forward, especially things like multiple myeloma that we're getting new information on. So please, reach out to the team. If you've had an allogeneic transplant, I'm happy to see you. And if not, again, hopefully it's something that we'll have available in the future as the treatments continue to evolve and improve and outcomes continue to get better.
Thank you so much, Melissa. Thank you for the presentation. And to our participants, just to remind you, Karen and Melissa were kind enough to provide us with the slides from these two presentations. So we're going to make sure that we get those out to those that have registered for the program, and you can review some of the information that they presented tonight. That's the conclusion of our program tonight. And we want to thank you for joining us today, for participating in this important topic. Please send us any other additional questions you might have. We'll try to get that routed to the correct people within the Cancer Center so that you can get your questions answered. Have a good night, and we'll see you at the next Cancer Connections. Good night.